Hi everyone, welcome to today's LACNETS webinar. I'm Lindsay Judovine, the Director of Communications for LACNETS.
And I'm Lisa Yen, the Director of Programs and Outreach for LACNETS.
Before we get started, I'd like to take a second to thank Rich at TVP Live for making today's webinar and high-quality production possible. We'd also like to thank our supporters, Ipsen, Advanced Accelerator Applications, Novartis, Tercera Therapeutics, and ITM Isotope Technologies Munich SE. Be sure you're following LACNETS on social media. Stay up to date on upcoming webinars and net news. We're on Facebook, Twitter, and Instagram with the handle @LACNETS. I'd like to remind our viewers that these webinars are done for educational purposes only and do not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. And now I'll pass it to you, Lisa.
Thank you, Lindsay. LACNETS is a program by Generate Possibility, a registered nonprofit, and it stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. Our mission is to provide education, advocacy, and support for all people impacted by this uncommon disease that used to be known as carcinoid, an old term meaning cancer-like. You'll often hear us say neuroendocrine cancer as a patient-friendly way to say the official medical term neuroendocrine neoplasia, which is an umbrella term for both neuroendocrine tumor, or NET, and neuroendocrine carcinoma, or NEC, NEC. We also say neuroendocrine cancer because we understand NET is a type of cancer and not cancer-like or benign as previously thought. While you often see Lindsay and I leading the meetings and programs, we are led by a team, which includes our Executive Director and Board Member, Kavya Vela-Caputi, and Board Member Donna Gavin, who is also the sister of LACNETS founder and Executive Director Emeritus, Giovanna Joyce Imbesi. Our board also includes Mary Dunleavy, who has been living and thriving with NET for over 17 years. I'm pleased to introduce today's speaker, Dr. Randy Hecht, who joins us from UCLA. Dr. Hecht is a professor of clinical medicine in the David Geffen School of Medicine at UCLA School of Medicine. He holds the Carol and Saul Rosenwig Chair for Cancer Therapies Development and is the director of UCLA Gastrointestinal Oncology Program. Dr. Hecht attended medical school at Eastern Virginia Medical School. He completed his internal medicine residency at Northwestern and fellowships in gastroenterology research at the University of Chicago and gastroenterology and medical oncology at UCLA. What this means is that Dr. Hecht trained as a gastroenterologist before he became a medical oncologist. He now runs the GI Oncology Program at UCLA and is the medical director of the Neuroendocrine Tumor Program, where he runs the multidisciplinary NET Tumor Board. In addition to being dedicated to patient care, he is an active researcher in the field of gastrointestinal cancers. I'll also share my disclaimer that I have a special connection with Dr. Hecht as he has been taking care of my husband for almost 8 years. Like many others, my husband was diagnosed initially in the community where he was seen by a community oncologist and a surgeon. It was my brother who understood that seeking an expert opinion is essential, and my brother found Dr. Hecht and arranged an appointment with him. And we now have found that seeing a NET expert has made all the difference in my husband's care. I'm excited to welcome Dr. Hecht today to talk about NET medical therapies. Welcome, Dr. Hecht.
My name is Randy Hecht, and I'm a GI oncologist at UCLA. I run the GI cancer program there, and also am the medical director for the Neuroendocrine Tumor Program. And it is my pleasure and my honor to talk about medical therapy of GI neuroendocrine tumors. And my title is Many Nuances, and that's part of what people who take care of neuroendocrine tumors actually deal with, and finally some new treatments. Before I start, I really would like to thank the LACNETS group. I've been working with them for many years. They truly are a model, not just for the neuroendocrine tumor community, but really as an advocacy group for, for all types of cancer. And I have nothing but praise. I think it's not that common that you have an advocacy group that both helps patients and really also helps the physicians who take care of those patients and helps move things along. So with that, let me go ahead and talk about this topic today. First, I'm going to make the assumption that many of you who have neuroendocrine tumors actually are quite educated in the disease. And in fact, one of the things that we've said for decades is that patients who have neuroendocrine tumors actually frequently know more than their physicians. But I'm going to make the assumption that at least some of you actually are not as familiar with neuroendocrine tumors. And so you can get a cup of coffee when I talk about the, sort of the elementary stuff if you're one of the advanced students who knows more than their physicians. But otherwise, please bear with me. So what are neuroendocrine tumors? Neuroendocrine tumors rise, not surprisingly, from cells that are called neuroendocrine cells. And these are cells that make hormones, not sex hormones like estrogen or testosterone, but hormones, for example, like insulin or gastrin that causes your stomach to make acid. And these, in many respects, help coordinate a lot of processes. In particular, in the GI tract, they coordinate digestion. Patients who have mutations in these tumors, in the DNA, these cells can start to build up. They form tumors, which are masses or swelling, and they can spread to other places. The most common site for neuroendocrine tumors are the GI tract, and people have really no realization how complicated digestion is. I mean, we eat, we go to the bathroom, and you don't really think about all the stuff that happens in between. That's really carefully coordinated both by a huge number of nerves, but also a very complicated system of neuroendocrine hormones. And this is what goes wrong. There are also neuroendocrine cells in other parts of the body that are important, in the lung, the thymus, the adrenal gland, in the master gland of the pituitary. However, the majority of the tumor cells are in the GI tract. So this is a photomicrograph, in other words, looking under the microscope at a stained neuroendocrine tumor. Without going into it, I like to say this is what the enemy looks like. They actually tend to be very normal looking cells. That's what well differentiated means. And the majority of neuroendocrine tumors are well differentiated. And we'll talk about a little bit more what that means and how important that is. But this is what the majority of neuroendocrine tumors look like. So how do we classify neuroendocrine tumors? Even though they may look very similar under the microscope, there are differences. And those differences include what organ they came from. The biggest difference is actually between the rest of the GI tract and the pancreas, but there are differences depending on what organ they started. There are also differences from an embryologic standpoint. Believe it or not, your GI tract is broken up into the foregut, the midgut, and the hindgut. Yes, we use those terms. And there are some differences in the cells that make those up and the neuroendocrine tumors that come from those. Then, as I mentioned, differentiation is really important. So when we use the term differentiation, we say how, normal cells in these neuroendocrine cells or other cells, they differentiate from kind of the primordial cell to really specialized cells that have a certain look. Well-differentiated neuroendocrine tumors, the cells look very much like normal neuroendocrine cells. While poorly differentiated neuroendocrine tumors, the cells have really lost that look and they act very differently. We'll talk about that. The other way that we characterize, and this is perhaps one of the most important, is how rapidly the cells divide. There are a number of ways that can be measured. In order to do that, you need a sample. That sample of the neuroendocrine tumor is stained. Historically, we looked at what was called mitotic rate. And you remember back to high school biology, mitoses are the cells dividing, and you can count those. So an easier way to look at this is actually a special stain that stains dividing cells called Ki67 or Ki67. And this is a bit what it looks like. So you can see down in the lower right, these cells which actually are stained for something, if you look in a little bit upper, called chromogranin A, that says, yes, these are neuroendocrine cells. If you look at number F, you can see the brown staining is very few cells. So that tumor has a very low Ki67 rate. The pathologist will actually count up to 500 cells before giving you a percentage. The one on the right, under G, has a much higher rate. So the lowest grade ones are called grade 1, and they tend to do better than grade 2, but this is a pretty old slide. And to be honest, ones that are low or intermediate grade, grade 1 or grade 2, those patients really, almost no matter what we do, they tend to do well. Grade 3 neuroendocrine tumors are, and to a most part, a different disease. So this is the table that I was talking about. NETs are neuroendocrine tumors. NECs are neuroendocrine carcinomas. Those are the high-grade ones. The ones that are well differentiated, in other words, the cells look very much like normal neuroendocrine tumors, are the NETs or NETs. You can see by either mitotic rate, or by really most of the time we use the Ki67. So grade 1s have less than 3% of the cells are staining for Ki67. Grade 2 is 3 to 20. Grade 3 is over 20. Most of the time, mitotic rate and Ki67 really move together, but there are some, particularly in pancreatic neuroendocrine tumors, at the upper level of the Ki67. Sometimes there can be some discordance there. But generally, the thing you want to ask your doctor about your tumor is, what was my Ki67? So let's talk about neuroendocrine tumors. There are two ways that neuroendocrine tumors hurt people. One is by their hormonal symptoms. In order to cause hormonal symptoms, they have to spread, usually to the liver. I have many patients who come in with a very small neuroendocrine tumor that has been removed, and they're convinced they have something called carcinoid syndrome. Carcinoid is another name for a neuroendocrine tumor of the GI tract and others, but not for pancreatic neuroendocrine tumors. But in patients who do have liver metastases, they often will have hormonal symptoms, which can include flushing, diarrhea, are the most common. If they're pancreatic neuroendocrine tumors, they can be from the hormones that are made by those cells there, which can include gastrin, which causes ulcers by causing acid, insulin, which causes low blood sugar, other hormones that can cause diarrhea. But what happens is that because these tumors are often slow growing, people can have side effects either from the hormones or the other way that neuroendocrine tumors hurt people, which is basically by slowly getting in the way. And it's known that patients can have symptoms really for years that are very nonspecific before they're finally diagnosed. So how do we treat patients who have neuroendocrine tumors? I'm only going to talk about medical treatment today, but this is a field where multidisciplinary care of patients is critical. And most of our patients that we have questions about, we meet in our multidisciplinary tumor board. We discuss with all the different modalities and all the different types of doctors that are involved. That includes nuclear medicine doctors, radiologists, interventional radiologists, endocrinologists, geneticists, gastroenterologists, surgeons, which include hepatic surgeons, surgical oncologists. All those people work together in the care of a patient who has neuroendocrine tumor. What I'll talk about today and focus on is the medical treatment. By that way, I mean giving drugs, whether they're injections or whether they're pills. So I was talking about somatostatin receptors, and as I said, almost everyone who's on this call has sort of been involved with this one way or the other, either in staging or in the treatment of neuroendocrine tumors. And so remember I said that neuroendocrine tumors come from cells that make hormones. And those cells and the hormones that they make are part of a circuit, and they tell cells often in the GI tract to do something. Those cells say, yes, thank you very much, and we have done it, and they send a turn-off signal to the neuroendocrine tumor. That turn-off signal is called somatostatin. And it turns out that this forms basically a circuit, sort of like your thermostat, your air conditioning goes off when it gets cold enough. And those receptors, which I liken to satellite dishes, are on the cell. There are at least 5 different types of receptors. And particularly the grade 1 and the grade 2 neuroendocrine tumors retain those receptors, and they retain the machinery, this turn-off machinery, and makes it a very attractive target for the treatment of neuroendocrine tumors. And so there you can see that on the surface of the cells are these fairly complicated receptors, 7 transmembrane receptors, and they generally still function in neuroendocrine tumors. There are other targets which actually are generally within the cell, we'll talk about later, like VEGF or angiogenesis, mTOR. These are all basically amplifiers of signals for the cells to grow. By turning off these growth signals, we can turn off the growth of these tumors. So somatostatin, with that natural turn-off hormone, lasts for minutes. And so when it was first synthesized, people in the very early trials who were having mostly hormonal problems, they would walk around with IVs because as soon as they turned it off, the somatostatin was gone. However, there was extremely effective in reducing hormonal symptoms for these patients. When patients have lots and lots of hormonal symptoms, what's called carcinoid crisis, it's the treatment of choice. It turns off relatively rapidly. Now, later on, they developed other drugs, what are called somatostatin analogs or SSAs. The first one is called octreotide. These are peptides, meaning they're basically strings of amino acids like the building blocks of protein, and they hit that receptor. The original octreotide is short acting, and some of you may have had this where they're shots that are given several times a day. They last longer than the parent compound, but they don't last that long. And then, really, one of the revolutionary things were what are called depot or long acting versions, and you're probably familiar with long-acting octreotide would last for a month, or a very similar drug, which is called lanreotide. The brand names for those are somatostatin or somatulene, that we tend to use the generic names, and those can be given as once a month and still have excellent effects, particularly on the hormonal effects. There's no evidence that I'm aware of any trials that looked at these head-to-head, and both of them seem to be effective, both from a hormonal standpoint, which is really what particularly octreotide was developed for. And then what we found out is that even though these are slow-growing tumors, that in general, patients who are on these drugs seem to have slower growing tumors, and a few percent, low single digits, actually had shrinkage of their tumors. Because of this, there were actually several trials that were done saying, okay, we know these drugs are really good against the hormones. Do they either make the tumor shrink, which is not that common, or do they, more importantly, keep them from growing? So one of the first trials, this goes back to 2009, was the PROMID trial, looking at midgut and given once a month. And the word that we use is progression. Now, for those of you who are new to oncology, one would think progression would be good, but actually, as an oncologist, progression is bad. That means the tumor is getting bigger. So we use something called progression-free survival, meaning how long did it take, or in this case, it was an older version of that called time to progression, TTP. And how long did it take for the tumor to get worse on CT scans? And what you can see is that the upper line, which is the dark blue versus the teal down at the bottom, so people who were getting octreotide had a much longer time before their tumors got worse than people who ended up getting placebo. And in fact, some people stayed on for really long periods of time, and that's been my experience as well. One thing that's also interesting is that even people who are getting placebo, that shows how often low to intermediate grade neuroendocrine tumors can be slow growing. Some of them went for as long as 2 years before their tumors got worse, and I've seen that as well, people we've decided to watch. Now, lanreotide is similar. This was a bit of a broader trial and a larger trial looking at this. This was called the Clarinet trial. You notice many of these trials end in net. But anyway, and this was a large randomized trial, really specifically looking at progression. And what you can see here is that patients who were on lanreotide took longer before their tumors grew. And once again, though the scale is a little bit different, it took them a long time. These trials were different. You can't really compare head to head. You can't look at the results. All we know is both of them were better than placebo. The patients who came in were different. The endpoints were different. But all we know is that both of them seem to work. So from an anti-tumor standpoint, either octreotide LAR or lanreotide are very reasonable options. And that's normally what people get with newly diagnosed, incurable metastatic disease. There are some newer somatostatin analogs. People really get tired of having a needle, once a month. So there's a company called Cameras that has a subcutaneous, so not so deep a needle, and that's a large phase 3 trial that's underway. People are particularly interested in the idea of oral. Basically, they're not really somatostatin analogs, but they hit the somatostatin receptor. So one question sometimes people ask is, well, Dr. Hecht, why can't you just take the stuff out of that really large syringe, and why can't I just drink it? And the reason is because they're basically the building blocks of protein, and it would get digested by your stomach. But there is some new drugs, one called Somatostatin, and that is not a peptide. It's absorbed, and it hits the somatostatin receptor. And in fact, we're in the process of opening up that trial as well. At least in other diseases where somatostatin analogs are used, it seems to be effective. And we hope in neuroendocrine tumors will be effective as well. What about other medical therapies? We do use chemotherapy. So first of all, what is the definition of chemotherapy? If you really wanted to be strict about the definition of chemotherapy, that means a chemical. That means anything we put in your body, anything other than surgery or radiation. But really, when we talk about chemotherapy, we talk about cytotoxic chemotherapy. So it's different than hormonal therapies, different against so-called targeted therapies, which I'll talk about later. But of course, every cytotoxic chemotherapy has targets. Cytotoxic means it kills cells, and most of the time they kill cells by mucking up DNA. So when the cell divides, it dies. Now, one of the things that we know that in general, pancreatic neuroendocrine tumors are much more sensitive to cytotoxic chemotherapy than other non-pancreatic GI neuroendocrine tumors. There are biological differences, even they look the same under the microscope, and we often consider them in the same, in the same thought. But there are differences, and actually there are different mutations between them. The drugs that we've looked at most, there's an older drug called streptozotocin, and that I have never, I take it back, maybe one time when I was very young and did not have gray hair, have seen used, but generally not used. It's an old toxic drug that's mostly used in animal studies to make animals diabetic because it hurts their neuroendocrine cells in their pancreas. There are more recent combinations, and the one that's looked at most is called temozolomide. The brand name for that's Temodar, and that combined either alone combined with another oral drug. They're both oral, called capecitabine. The brand name, though they've all been generic for years, is called Xeloda with an X, so you hear it referred to that way. Now, sometimes we use chemotherapy, particularly that is useful in other GI. For patients, particularly ones who have a higher Ki-67, more than 20%, but particularly if it's under 55%, that drugs that are used for other GI malignancies, including drugs like capecitabine and another one called oxaliplatin, have been used. The lower the grade, the less responsive it is to these tumors, but those that are well differentiated grade 3 certainly can respond. And then high grade tumors, those tumors in general are treated like neuroendocrine tumors of the lung, something called small cell carcinoma of the lung. These cells are really rapidly dividing. They're very sensitive to chemotherapy. We use very aggressive chemotherapy based on lung cancer chemotherapy. However, their responses tend to only last for so long as opposed to the low to intermediate grade patients. So this is just once again saying what I had already said about streptozotocin, which is, as I said, is an old drug and never used. Temozolomide by itself, there's early data. This is from John Strasberg, and a number of centers have actually published early trials looking at either temozolomide alone or in combination with capecitabine. Temozolomide is an oral drug that also crosses the blood-brain barrier and is not approved, but is used frequently in neuroendocrine tumors. It's actually approved in brain cancers, particularly the worst type, glioblastoma multiforme. From studies in brain cancer, it was shown that a specific genetic marker called MGMT deficiency correlated with effectiveness. And it turned out that a couple things. One is that this MGMT deficiency is a lot more common in pancreatic neuroendocrine tumors. And it is not very common at all in non-pancreatic neuroendocrine tumors or carcinoids. And we also know that this combination works much better in pancreatic neuroendocrine tumors. And even though there's small series of people claiming that it works to a small percentage in carcinoids, that still I don't think it works that well. And much more active in pancreatic neuroendocrine tumors. And this question about NGMT deficiency, and there are a number of places where that can be lost, may explain this differential. So if you're looking, this is what's called a waterfall plot, looking at maximum response. Down is good, looking like a waterfall. And you can see that this is in a small study that most of the patients had tumor shrinkage. Remember, we're happy with tumors not growing, so tumor shrinkage is nice. So Pam Kunz, who has been at several LACNETS meetings and talks, used to be at Stanford, now is at Yale, and she presented this updated data from the ECOG Akron E2211 trial. These are cooperative groups. These are your tax dollars at work doing basically trials with drugs that are generic and therefore don't get much pharmaceutical industry support, but are really, really important to our patients. So this was a randomized trial, meaning a coin flip decided who was going to get what, of either temozolomide alone or temozolomide plus capecitabine. This is what's called a phase 2 trial because it wasn't that large. It also really didn't have a control arm because both of the arms really were with active drugs, but looking to see how much does capecitabine really add. So first of all, this is actually from Pam's more recent presentation. She presented a little while ago the early data. She presented the updated data in June at our national meeting, showing these very small studies to the right of combinations of temozolomide, either with drugs that block the growth of new blood vessels, with capecitabine alone. But you can see that while the response rates are high, the numbers are really small. And there are also some theoretical reasons why capecitabine, this other pill that's used in many other cancers and is well tolerated, may actually have a biological reason, not just, throwing spaghetti at the wall and seeing what sticks or throwing two drugs together, but it may actually have an effect on that marker, MGMT, that might actually make tumors more sensitive to the temozolomide. And this just goes through in more detail how it works, and basically by mucking up the DNA, and also about MGMT. Usually, at least in brain tumors, it's silenced by what's called methylation of the promoter. These are basically turning off the gene in the genome. But one of the points of the trial is to see whether it made a difference in neuroendocrine cells and neuroendocrine tumors. So this was the study design. Arm A was temozolomide alone, given the standard way, which is days 1 through 5. And then the other was a combination of capecitabine and temozolomide, and this is actually worked out from other trials. Patients, once again, were randomized by coin flip. Not that large. This was pancreatic neuroendocrine tumors only. So the original endpoint was progression-free survival. And because that's really all you have control over, you don't have any control over what happens after someone's tumor gets worse. And these are actually, thank you, Pam, for doing UCLA colors, but the gold on top is a combination, while the one on the bottom, which is temozolomide, and you can see that both of them had patients took a long time before their tumors got worse. So, there was no winners or losers. Cape-Tem looked a little bit better, though. This is overall survival, which is what people care about, but what you can see is that it took a long time. First of all, most of the patients are still alive, or about half of them, and often for a long period of time. This is following people for up to 5 years. We don't know what happened to them afterwards. For example, people on the temozolomide arm might have gotten capecitabine and temozolomide afterwards. The other thing is that we call objective response. We have basically, in order to we call a response in oncology, tumor has to shrink at least 30% in the largest and in one of the diameters. And what you can see, that's called a partial response. If it goes away completely, that's a complete response. These are very rare in most diseases, including neuroendocrine tumors. But you can see a large percentage, a third of the temozolomide alone, 40% of the Cape-Tem, ended up having responses. So the other thing, which I didn't go into because it's not quite ready for prime time, is that the patients who did have deficiency in MGMT did have a significantly higher chance of responding, particularly to the temozolomide alone. However, it's not ready for prime time yet, so I can't say that you should be testing people before they go on Cape-Tem. So let's talk about some other medical therapies. These are newer drugs. They're called targeted therapies, but as I mentioned, every drug has a target. mTOR is a pathway that actually has to do in normal physiology, sort of downstream of actually sugar uptake and insulin. VEGF, we'll talk about the growth of new blood vessels, and that's also sort of related to a new drug which blocks something else in those pathways called HIF-1 alpha. So as I said, mTOR is downstream. These are found in every single cell. And one of the problems is that when you're looking for targets, if you knock out something that's important for every single cell, you end up with a lot of toxicity. But most of this is actually downstream of sometimes what's called nutrient sensing. And up at the top are other receptors. Remember those satellite dishes, while the ones for somatostatin are a different type of satellite dish. These are called tyrosine kinases, and we'll talk about, and in fact, the majority of receptors signals for cells to grow, and a lot of our targeted therapies are called tyrosine kinase, either antibodies against them or tyrosine kinase inhibitors. And you can see to the upper right talking about nutrients and metabolites. So one of the first drugs actually to block this mTOR, which stands for mammalian target of rapamycin. Rapamycin is a drug that's used in transplant It actually comes from a fungus from Easter Island, Rapa Nui. And this is actually a variant of that. I can't say that it's actually better than rapamycin, but I know rapamycin is generic. And so this drug, which is called everolimus, it used to be called RAD-001, and all the trials start with rapamycin, starting for rapamycin analog, was the RADIANT-3 trial. This was a large trial we took part in. It was in pancreatic neuroendocrine tumors. It was versus placebo, the drug which is called everolimus or Afinitor. These were randomized. Patients could cross over, so overall survival is not useful. And what you can see is that patients did better on the everolimus. And actually, James Yao presented this a number of years ago. So this was in pancreatic neuroendocrine tumors. It reduced the risk of progression really by about 2/3. So at any one time, people who are on the everolimus were 2/3 less likely to have their tumors grow than people who weren't. There's toxicity, particularly at the higher dose of this, and mouse sores are the ones we see the most, but also high blood sugar, rash. But it's definitely a drug that has activity. But I think that more modern drugs we'll talk about, and are probably where I'd go first, but it does have a place, in my back pocket. What about non-pancreatic neuroendocrine tumors, carcinoids? This was the RADIANT-4 trial. Similar design, though a randomized 2-to-1. And what you can see here is that patients who are on the everolimus also were about half as likely to continue on the drug at any one time point than people who are on placebo alone. So what about other pathways? We've known for a really long time that neuroendocrine tumors have lots and lots of blood vessels. We can actually target that a number of ways. For example, some of the destructive therapies I mentioned at the beginning included embolization, which is blocking off the blood vessels. We also know that tumors basically need for the patient, the host, to grow new blood vessels to feed it. It's kind of like Little Shop of Horrors. Feed me, because if they don't get fed, then by blood and nutrients from those blood vessels, then they can't grow. Now, of course, this is something that's really highly regulated, as you can imagine, but once someone is grown, they really don't need a lot of new blood vessels. They need it as a fetus, they need it as a growing child, they may need it to heal a wound, but in general, this is something that we can target without hurting the host too much. For reasons that are not totally clear, even though this is very highly regulated, the vascular endothelial growth factor family, which is fairly complicated because your body wants to fine tune where the blood vessels are, how much you're growing. You don't want to have it. And so there are multiple different receptors, those satellite dishes, and multiple different signals, sort of like different channels coming in over the air. But the one that seems to be most important is called VEGF-A, and the receptor, which is vascular endothelial receptor 2, seems to be the one that's most important. And in many different cancers, drugs have been developed, and one nice thing that we're able to do in the neuroendocrine tumor community is take advantage of those drugs that were already developed for other tumors. So sometimes these drugs are called anti-angiogenesis agents. There's a drug called bevacizumab or Avastin, which actually we did the first trials with at UCLA many years ago in colon cancer. And even though it's not really used in neuroendocrine tumors, we know that at least some patients had benefit from it. That's an antibody against the signal. So instead, we have what are called tyrosine kinase inhibitors. These are small molecules. They're almost always given as a pill. They're well absorbed. And they, in effect, the way I think about it is that while antibodies block something, either the signal or the sort of like pouring cement into the satellite dish, tyrosine kinase receptors work a little bit downstream. So it's sort of like in your satellite dish, it's like cutting the wires that come out of the satellite dish. So once again, there's no signal to grow. Now, the problem is that while antibodies are very specific, so if you have an antibody against something, that's basically all you're going to hit. But the tyrosine kinases, which are these signals, these receptors, all actually from an evolutionary standpoint came from some very, very early cell that had them, and they've been modified over the years. And the problem is that the drugs that we have developed to block one, like VEGF receptor 2, also have off-target toxicity. Now, if that's good, because blocking those other pathways are important in blocking the growth of the cells, that's good, and we call that a multi-targeted agent. If it's bad, then we say it's dirty, and often those off-target effects actually lead to the toxicity. So here's some background from a presentation from the ubiquitous Pam Kuntz's talk that was given recently, about a year and a half ago, summarizing some of the data that we have with tyrosine kinases, or to their friends, TKIs. And what you can see is to the right, this is the arterial phase of a CT scan, meaning that right when that contrast goes in, and you can see the contrast, which is what goes into your arm, lights up in the holes in the liver, which is to the left, because so much blood is going to the neuroendocrine tumors. And there are lots of drugs that have been developed, hundreds actually of tyrosine kinase inhibitors have been developed. Some of them have made it into humans, and we've worked with many of them, but I'll talk about some of them, including pazopanib, surufatinib, and cabozantinib. If you notice that they all end in ib, and that means they're inhibitors. So that's how you know a tyrosine kinase inhibitor. On the other hand, things that end in MAB are monoclonal antibodies like bevacizumab. So let's go on. This slide goes over some of the anti-VEGF inhibitors, the tyrosine kinase inhibitors that we have available. Actually, hundreds have been synthesized, and tens have actually gone into people, and a large number are already approved in a number of different diseases. So we have the ability to actually test these drugs that we already know the safety, we already know the dosing, and we can look at them in rarer tumors like neuroendocrine tumors. Only sunitinib, which is approved in certain other diseases like gastrointestinal stromal tumors, renal cell carcinoma, is actually FDA approved in neuroendocrine tumors, but there are others that we're doing trials in, and just because something is not FDA approved doesn't mean it can't be used, and just because something that's not FDA approved doesn't mean it may not be paid for as well, but what FDA approval does mean is that you can advertise it. So some of the others that have been looked at recently include pazopanib, surufatinib, cabozantinib, and as I mentioned before, and lenvatinib, which I think has some very interesting data we'll talk about. There was actually a large phase 3 trial about 10 years ago looking at sunitinib, and this was a trial, once again, versus placebo in pancreatic neuroendocrine tumors. And what you can see is that there was a significant difference in progression-free survival, in other words, how long it took for the tumor to grow, and that's at the bottom left. And it took about 60% longer for the tumor to grow in the sunitinib arm. And even though we had no control over what happened after the patient progressed, there was also an improvement in overall survival, though that did not reach statistical significance. Pazopanib has been looked at. This is actually Emily Bergsland up at UCSF presented some data a couple of years ago. Actually not as powerful a data, and these were in carcinoids. Once again, things seem to work a little bit better in pancreatic neuroendocrine tumors. And pazopanib, while I think there was some small differences and it was relatively well tolerated, and once again, up in the upper right corner, it doesn't just hit VEGF receptor, but it hits a number of other receptors, and this is no longer being developed. There's some recent exciting data that's been presented and published about surufatinib. This is a Chinese drug. What you can see is that there was a significant improvement, about a 50% improvement in what's called the HR, or hazard ratio, in progression-free survival, meaning at any one time point, patients who are on surufatinib were twice as likely to be able to continue or not progress than people who are on placebo. And then the survival data looks really interesting, but once again, this is afterwards, and that's not mature yet. This is not FDA approved in the United States. It is available in China. Is this any better? It's a very dirty inhibitor. It hits some things that may be interesting, but you have to show them to me, whether they make a difference. These are theoretical, but it's nice to have another drug that's potentially available. And as I said, it's under FDA review, but the numbers were relatively small, and whether or not hitting these other targets makes a difference, the proof is in the pudding. Sometimes hitting other targets causes more toxicity. Sometimes it may actually lead to better outcomes. All these drugs hit the main blood vessel growth pathway, VEGF receptor. Cabozantinib is a drug that is actually already approved in a number of different cancers. There's a large randomized trial from the Alliance, which has nothing to do with Star Wars, but is another one of our large government-funded cooperative groups, and particularly for rarer tumors, it makes sense to do trials through this. I think Jennifer Chan is the principal investigator on this. This is cabozantinib, which is a pill versus placebo. They're looking at both pancreatic and non-pancreatic neuroendocrine tumors. This is called the CABINET trial, and it is actively accruing, and I'm all for people going on studies. More recently, there was a trial called the TALENT trial, a smallish trial, so not as large as the last large randomized phase 3 trial. Very interesting data. This was presented and actually published this past year. Lenvatinib is mostly used in liver cancer, where it is FDA approved, in which you can see in these waterfall plots that patients in the top and under A, that almost half the patients had major shrinkage of their tumors with pancreatic neuroendocrine tumors, and about a sixth of patients had major shrinkage, but almost all patients had some shrinkage, at least initially in patients who had non-pancreatic neuroendocrine tumors. So this is something we've started using. It generally at doses that are very high, that are used in other diseases, not the easiest drug to tolerate, and like many of the drugs that we've worked with, we've come to realize that really what we need is not the maximum tolerated dose, but the dose that works without causing side effects. And we found this to be very tolerable at lower doses. So it turns out that there is a rare condition which is called von Hippel-Lindau disease that actually is a great example of how targeted therapies work. And in fact, it really shows that when you have the science and the background science, which was decades of research, that can lead to new drugs that can really truly help those patients who have those, who have tumors that have those targeted problems. Now, this is a very small group of people. Now, it turns out that patients who have von Hippel-Lindau disease have lots of different tumors. And the one that I circled in bright red, that includes pancreatic neuroendocrine tumors. But really what it's best known for, which unfortunately is actually kidney cancers. But they also have many different other cancers. And these people have a mutation in the gene called VHL for von Hippel-Lindau who have this disease, and they do get all these tumors. And this has been known for a very long period of time. Now, it turns out that, as I said, decades of science showed that the gene that's responsible, which is called VHL, turns out to be really important in signaling low oxygen. And your body does not like low oxygen. It's bad for your body, and has hundreds of millions of years of basically components to say what happens when the oxygen is low. You've got to do things. And one of the things it does is it signals to grow new blood vessels. Even some of these, part of this cassette, also signals the growth of new red blood cells. But VHL seems to be important in that. And remember, as I said, it makes sense, since these tumors often need lots of blood vessels as part of their blood supply, that this would be an interesting target. Now, it does turn out, though, that VHL mutations are relatively uncommon, even in pancreatic neuroendocrine tumors. But among this group of patients, pancreatic neuroendocrine tumors are relatively common. And this is the part of the pathway. I put the sort of the teal arrow about the drug that I'm going to talk about, belzutifan. Basically, if you have a mutation, this is upstream. If you notice, if you look down at the bottom, you can see VEGF. And so this is all part of that same pathway having to do, and then if you look even further down, you can see the inhibitors that I was talking about. So this inhibitor actually works upstream. So it took a large number of people, and this was published recently in the New England Journal of Medicine, using this drug mostly for renal cell carcinoma. That's kidney cancer, and that's the most common cancer that these patients have. But they also, and you'll see in just a minute, that they also had pancreatic neuroendocrine tumors. And so since we're not talking about kidney cancer right now, I'm cutting to the chase. And when you look, in this group of patients, a lot of them had pancreatic lesions. They weren't all documented as pancreatic neuroendocrine tumors, but of those that had pancreatic neuroendocrine tumors who end up getting the new drug, that 90% of them had major shrinkage. And in fact, 14% of them, 3 out of the 22, had actually complete disappearance of their pancreatic neuroendocrine tumor. And then finally, if you look, there's CR means complete response, PR means partial response, SD means stable disease, PD means progressive disease. In other words, the tumor getting worse. At least at the first look, none of them got worse. And as I said, 90% of them, 91% of them ended up having at least a major response. So showing really the power of targeted therapies. While this is a small group of patients, it is important. I think it's a great proof of principle. And for those patients who have von Hippel-Lindau disease, it's something that it really has been a game changer. So One of the last things I really wanted to talk about was, well, we've talked mostly about grade 1 and grade 2 tumors, but there are people who have grade 3. And one of the things that we've realized for the last several decades is that not all grade 3 tumors are the same. So they're the bad ones, the ones that are poorly differentiated and have a very high Ki-67. The cells are dividing very rapidly, that are very sensitive to chemotherapy, but tumors tend to be fast growing. We also know that patients who have a Ki-67 of 21%, whose tumors are well differentiated, act just like someone, in fact, I would say are indistinguishable from someone who has a Ki-67 of 19%. And so these clinical observations actually have made it into our grading systems. And what we know is that patients who have grade 3 neuroendocrine tumors, more than 20% Ki-67, who are well differentiated, the tumor is well differentiated, particularly if the Ki-67 is less than 55%, are called grade 3 NETs, or grade 3 NETs. And they may be more sensitive to chemotherapy that are used in lower grade ones like oxaliplatin. On the other hand, the ones that are poorly differentiated, and they generally have a Ki-67 greater than 55%, they're called NECs, or neuroendocrine carcinomas, grade 3. And they act much more like that lung cancer I was talking about, small cell. They respond to drugs that we use in small cell carcinoma, like platins, carboplatin or cisplatin, and another drug called etoposide, very high major response rate. There's another drug called irinotecan that's used. Those drugs that we use in the NECs, or the neuroendocrine carcinomas, actually don't work that well in the grade 3 neuroendocrine tumors, and vice versa. So it's important. This is really an important clinical distinction. And within the last 2 or 3 months, I've seen patients who've gotten chemotherapy for high grade neuroendocrine carcinomas who really were just, had a Ki-67 that was in the 20%, and they were not going to respond, and they didn't respond, and they had all the toxicity and none of the benefit. So one of the things that my patients almost always ask me about is, what about immunotherapy? Immunotherapy is advertised on TV. A lot of the early studies were done in melanoma and by my colleague Tony Rebus, and the first studies in lung cancer, which is why they're advertised, were done by my colleague Eddie Guerin. And what we know is that in those diseases they work. We also know that in patients who have sometimes called MSI, which is, without going into the term, microsatellite instability or deficient DNA mismatch repair, where the spell checker is broken, that there's some cancers of any type of cancer who have lots and lots and lots of mutations. This happened to be colon cancer because of the slide that I had. They have thousands of mutations. Actually, neuroendocrine tumors have very few mutations, almost fewer than almost any other type of cancer, unless you have that spell checker mutation, which is unfortunately relatively rare in neuroendocrine tumors. Why is this important? Why do we care? And the reason is because those immunotherapies, the now standard immunotherapies called checkpoint inhibitors, that work really well in melanoma, they work really well in lung cancers, they work really well in patients who have thousands of mutations. Those are the green and the black on top. They just don't work particularly well. And as I say at the bottom, neuroendocrine tumors actually generally have very few mutations. Another way to quantitate that, you'll see if you get next generation sequencing, you'll see on the report, it's called tumor mutational burden, or TMB, and neuroendocrine tumors have some of the lowest TMB. So basically these drugs like Keytruda, which is pembrolizumab, or Opdivo, which is nivolumab, they don't work. Unfortunately, there have been a number of small to medium-sized studies showing that they don't work very well. What about grade 3 neuroendocrine tumors? Now, it turns out that type of neuroendocrine lung cancer called small cell carcinoma of the lung, actually, these do work to a certain extent. Also, we know that those mutations that lead to thousands of mutations are a little bit more common in grade 3 neuroendocrine tumors, and particularly neuroendocrine carcinomas, up to 5%. So in these tumors, there have been some small studies using in salvage as a single agent. I don't think they're that effective. There's some small studies looking at a combination of two different checkpoint inhibitors, nivolumab and ipilimumab. Notice they end in mab, so they're monoclonal antibodies. Actually seem to have some benefit. There are ongoing trials, and I think it's reasonable in those patients who have high-grade neuroendocrine carcinomas in particular to consider immunotherapy, especially since we don't have a lot of data on salvage, meaning after first-line therapy. Finally, I want to finish up about medical treatment of hormonal symptoms. So most of what I've talked about have been patients who have hormonal symptoms that are under control by their somatostatin analog, octreotide or lanreotide, but they're getting into trouble because their tumors are growing. But we do also, treat hormonal symptoms. There are a couple different ways. As I just mentioned, somatostatin analogs or SSAs are very effective. If they don't work, there are a number of things you can do. You can increase the dose. You can decrease the interval between the dosing, which is similar to increasing the dose. One of the things that we see sometimes are people whose hormonal symptoms show up in the last week before they're ready for their next shot. That's telling you either need a higher dose or to decrease the interval. Sometimes we will go in and debulk the tumor. The tumor is what's making the hormones. That can be surgery or other ways of making holes. But the one thing I wanted to finish up with for medical treatment is diarrhea. Diarrhea is one of the more common things that we see in neuroendocrine tumors. One of the first things is that not all diarrhea in a patient with neuroendocrine tumor is due to their neuroendocrine tumor. So even though most of them are on somatostatin analogs, if someone still has diarrhea, you have to look at what are the other causes, particularly for patients with pancreatic neuroendocrine tumors who've had surgery or other destructive things to their pancreas. Most of the pancreas actually is not making neuroendocrine hormones, it's actually making digestive enzymes. And if you don't have those enzymes, then what can happen is that you don't digest fat. And if you don't digest fat, you end up having diarrhea. And that's called steatorrhea. And what we know is that getting pancreatic enzymes from the drugstore doesn't help this at all, but getting pharmaceutical grade digestive enzymes, which is sometimes called pancreolipase, that are designed to get down to the bowels, that actually can be very effective in patients. And there are stool tests they can do, or they can do it empirically. Also, some patients who have neuroendocrine tumors have had part of their bowels removed, or that's been bypassed, and patients who have short bowel syndrome can have diarrhea. That has its own sort of way of being treated. The most common place for patients to have non-pancreatic neuroendocrine tumors of the GI tract is in the very bottom of the small intestine called the ileum, and they have ileal carcinoids. Right there is a valve between the small intestine or small bowel and the colon. When people have surgery to remove, that valve is removed, and sometimes bile acids, which help you absorb certain fats but can be irritating, will get into the colon, and by binding those bile acids, that's called choleretic diarrhea, that can be very effective. And you can continue to increase your somatostatin analog all day, and it's not going to help it if that's not the cause of the diarrhea. And finally, people who've had surgery on their bowels can have what's called SIBO, or small intestinal bacterial overgrowth. So if you've had surgery, sometimes the contents of the GI tract sits there. It may not squeeze as well, it may be partially dilated. And actually the treatment for that is antibiotics, not more octreotide. There are kind of non-specific antidiarrheals that can be used. The most common one that we use is loperamide. Though it's generic, is also called Imodium. Lomotil, which is a combination of diphenoxylate and atropine, can also be used. And sometimes that, especially someone who has diarrhea, not infrequently, I had a patient yesterday who has diarrhea once every couple of weeks. Rather than starting him on something every day, we said, if you start feeling you have diarrhea, to take the loperamide. And finally, for that small group of people that you can't help by other ways, there's a relatively new drug which is called telotrestat, which is a targeted therapy. It blocks the enzyme to go from amino acid called tryptophan to one that's synthesized, it's called to serotonin. Tryptophan hydroxylase is what's called the rate limiting step. In other words, if you block it, it blocks everything else. Telotrestat, by blocking that, blocks the synthesis of chemical serotonin, which is responsible for at least some of the diarrhea that we see in carcinoid syndrome. Now, one of the problems with drugs that blocked this is that serotonin is also important in not being depressed. And so, in fact, most antidepressants also work on this pathway. So telotrestat does not cross the blood-brain barrier. There is a barrier to keep drugs out of your brain that's naturally there. By not crossing, it doesn't have as much a way of other effects on mood and on your brain, basically. So there have been several studies, but this one I happen to show, which is called TELSTAR, and what you can see is that patients who are on telotrestat had fewer bowel movements. I have to be honest that I don't use this drug that much because I would say that the number of patients who get to this point where the other things that we've mentioned before did not help is actually relatively small. So to conclude, I think it's important to know that we have many, many different potential drugs and potential treatments, not just drugs, for patients who have neuroendocrine tumors. It's really important to have the background information. Where did the tumor come from? What is the grade? In order to try to figure out which of these various options that you have. Unfortunately, one of the problems that we have is that there are very few studies to say treatment A versus treatment B. So sequencing our studies still is opinion. And this is why I think that patients should at least be seen at some point in time at a center like UCLA, though there's certainly other centers in town and around the country where we can discuss the potential risks, benefits, likelihood of benefit in any individual patient to try to sequence. I do think that all patients with metastatic cancer, whether neuroendocrine tumor or not, should have something called next generation sequencing. It's not that next generation. It's called NGS to its friends. And this looks at right now about 650 different genes that might be potential targets, and it's done most of the time on the tumor. There are what are called liquid biopsies, but I think actually looking at the tumor is probably more helpful. That being said, of all the tumors that I take care of as a GI oncologist, I would say that, to be honest, neuroendocrine tumors are least likely to have targets. However, if you find something, it can be life-changing, particularly this MSI, where immune therapies may be very effective. There is another one, without getting into too much into the weeds, called BRAF, that's found more in colon neuroendocrine carcinomas. But like they say, there's an app for that. If you find something, there may be a drug for that. So with that, I'd like to thank you for your attention. Once again, I would love to thank LACNETS for asking me to present and to talk. And once again, I want to thank you for everything that you do and for everything that you continue to do for so many patients. And at that point, I think it's time to answer questions. Thank you very much.
Thank you, Dr. Hecht, for that very informative presentation, very thorough, and we really are excited to hear all the advances over the past few years and all the upcoming trials as well. So thank you for that.
Well, thank you.
So in the next 30 minutes, we have lots of questions that have been filtering in. So let's go ahead and get started with some of them.
Yeah, I'll do the best that I can. So I'll try to generalize these things. But Lisa, you're a pro, so just start tossing me the questions. And so the first one that I see here, and also thank you for your attention for sitting through that. Are NET patients more likely to have other cancers, including other NETs? And the answer is sometimes. And there are inherited predispositions to neuroendocrine tumors, of which the most common one is MEN, particularly MEN1, multiple endocrine neoplasia, and they do have a whole spectrum of other malignancies. These patients often, in fact, we were reviewing patients, we talked about multidisciplinary conferences. We had one at 7 this morning, and we were discussing such a patient. And the treatment is a little bit different because they get multiple pancreatic neuroendocrine tumors, and you only want to take a little bit out, or you want to try to wait because this is a lifetime illness, and you want to have to maintain as much pancreas as possible. They can also have other cancers. They can have cancers in the area of their thyroid. They can have with pituitary. Now, once you get beyond, I mentioned VHL earlier in the talk because of the von Hippel-Lindau, because of VHL as a target. Once you get beyond that and you say that someone has had, let's say, a neuroendocrine tumor of their small intestine, of their small bowel, are they more likely to have cancers elsewhere in their body? And in general, someone who's had one cancer has a slightly increased risk of other cancers, but the answer generally is no.
Okay, thank you for that answer. As you have probably seen, there are young adults who also have NET. And what resources do you have or advice for young adult patients?
Well, first of all, it's funny. This morning I was commenting on just how young our patients were. Now, partly that may be the type of people who come to an academic center are more likely to be informed and motivated and mobile. one of my patients was talking about, I think is in her upper 80s, just looking at my notes right here. But so I think there are a couple things. One, it's really important, particularly someone who's young, to meet with a genetics counselor and to have genetic testing, particularly if there's any sort of family history, though that's uncommon. But I think it's important for not just for the patient and the management of the patient, but also for the rest of the family. The other question is, young people don't think, I feel very strongly, young people, no one's supposed to have cancer, but in particular, young people aren't supposed to have cancer. And I think that even though when we say that patients can do well for a very long time, I think the effect on someone who is, I was discussing a patient this morning who does not have an inherited predisposition, who's 25. Saying that to someone who's 25 is very different than saying it to someone who's 75. And we talk about sequencing of tumors, and sequencing of treatments. And what I always say is that with neuroendocrine tumors, you're playing the long game because patients can do so well. But I think that's even more important in younger patients. The other thing I think that we've come to realize is that many institutions have resources for young people with cancer. UCLA in particular has a program for adolescents and young adults. The other things that also come into play, particularly if people are getting radiation or radioactive treatments, is fertility. And I think it's important to have those discussions about fertility preservation. And also, the other thing that's really important, I think, for patients of all ages, but I think it may be more important for young patients, are psychosocial support. And I know at UCLA, we're fortunate to have what's called the Sims Mann Center, who are psychologists and social workers, many of whom are trained to work with adolescents and young adults. I think our peer institutions around town and around the country have similar programs. If for some reason you do not have access to something like that, the first thing that you should do is sort of ask your physician to say, what are these resources that are available?
Yeah, thank you for that, and
Mhm.
and for raising these topics that we needed to be talking about, such as
Mhm.
fertility and psychosocial issues as well. So let's get to some treatment-related questions, and there were several that came up about specific drugs. So is Afinitor used as an immunosuppressant for transplant patients? And can you be on it for many years, or do you have to be concerned about its long-term side effects?
So Afinitor, which is also called everolimus, as I mentioned, is very closely related to rapamycin or Rapamune, which has been around for a long time as a transplant drug. It is approved in a number of countries. Actually, I don't know in the United States. I remember it was approved in Europe for transplant. And so therefore, it is immunosuppressive. What I would say is that patients who have had transplants are on these drugs for many, many years and do well, particularly liver transplant patients. So I don't have, and there are some drugs that have a lot of long-term toxicity, and I'm not aware that this is one of those. I think the biggest problem with long-term toxicity that I have had with everolimus has been lack of long-term. And so, as I mentioned, even though I have had the occasional patient who's been on this for years, I can remember a patient from the original trials who eventually we ended up taking off because he'd been on for many years and the drug was commercially available and the sponsor wanted to close the trial. But in general, I think more people come off. Now, if you're one of those people who are doing well on everolimus, I think that's great and you should not switch. But what I would say is every single one of our drugs has potential side effects. But remember what we're doing. We're not treating someone for, for something that's trivial. We're not treating someone for a rash. We're treating someone for, with a cancer of some sort. So I think that's a discussion that you should have with your doctor, but I don't think it's incredibly immunosuppressive. I would also have a discussion with your physician, especially anything that's immunosuppressive, about making certain that you're fully vaccinated. And up until recently, we've been giving Evusheld to patients, but I'm a little concerned because the most recent variant may be resistant to Evusheld. In general, neuroendocrine tumor patients are not, I'm talking about for COVID. In general, actually, my patients are not that immunocompromised, and we have not been using Evusheld, which is a combination of two antibodies that's given once every 6 months, particularly for people with blood cancers who really can't make antibodies. My patients in general can make antibodies just fine. But I just was reading that there may be newer variants that are not a big part of what we see in the United States right now, but may be worse in the future, and it shows that you have to stay one step ahead of the virus. What you can do, because you can make antibodies, is make certain that you're up to date with your vaccinations.
Thanks for that. That's very timely. And
Mhm.
as it looks like, COVID is here to stay. So that's good to know. A follow-up question about Afinitor. Have you seen edema of the lower extremities as a common side effect of Afinitor?
Yes, I have seen it. Nefinitor everolimus has a lot of side effects, and which is, I have to be honest, is a reason that once we finish the trials, I haven't used it that much. It's kind of the, I would say that as long as it's helping you, I think that's great. The side effects that we tend to see are mouth sores, high blood sugar. I think one of the important things is dosing. Often the dose that's given is a little on the high side, and we frequently end up dose reducing. But the answer is yes, I have seen it.
Thank you for that. Another safety-related question. For well-differentiated grade 2 pancreatic NET with lymph nodes mets and negative dotatate scan, someone who's treated with CAPTEM, basically this person was told that they would stay indefinitely on CAPTEM if no progression. And I guess the general question is it safe to stay on CAPTEM for a long period of time, or how long?
So I think there are a couple things. One is because it's a two-line question, and there's lots of things to kind of unpack with that. One is that were the lymph nodes removed, and this is in what's called the adjuvant setting. So adjuvant means after surgery. Everything's been cut out. We call NED no evidence of disease. And then in many cancers, we actually give breast cancer, colon cancer, lung cancers, things I don't treat. I do treat colon cancer, but not the others. And we give medicines afterwards, and that's called adjuvant in addition. So if the patient had lymph node metastases that were seen under the microscope and were not, and they were removed, and there's no evidence of any disease, then I would say they should get no treatment. Now, if the patient had a well-differentiated neuroendocrine tumor and clearly has lymph node metastases now after surgery, and the dotatate scan is negative, that's uncommon. Over 90% of patients with well-differentiated grade 1 and grade 2 neuroendocrine tumors are dotatate positive. And so one question was the dotatate scan positive ever? And I would actually sort of try to figure out what those lymph nodes are, may even if they really are there, make sure it's not another tumor. Are they reactive? You might want to put a needle into those. But then to get closer to your question, I'm sorry, I couldn't avoid those because I'm trying to figure out why the person is necessarily on it. So capecitabine actually can be given indefinitely. And so I have had patients on for other diseases where it's used who've been on capecitabine more than 5 years and has no dose limiting toxicity. Temozolomide is an alkylating agent, and it's tougher. And there are theoretical reasons why alkylating agents can increase the risks of blood problems that could include sort of low effects on the bone marrow, which could cause low blood counts, and even pre-leukemia and leukemia, though I have never seen that. I would say once again, people are more likely to come off in the trials that were done. Most people ended up coming off. I would say that a lot of my patients on capecitabine and temozolomide either have to have significant dose reductions or come off because of their blood counts if they're on for a very long period of time. So I think that if the patient is doing well, you can stay on for years. And so I'm not too worried about that. But I would really make certain why are you on? And then it is a little bit unusual to have a negative dotatate scan. And so I would really want to make certain that this really is truly what we think it is.
Thank you for that. So we've talked about Afinitor and CAPTEM. How do you determine if you would prescribe CAPTEM or Afinitor?
For patients, obviously there are a lot of people here who have pancreatic neuroendocrine tumors. And so first of all, CAPTEM really has almost all the data is in pancreatic neuroendocrine tumors. While everolimus is approved for both pancreatic and non-pancreatic GI neuroendocrine tumors. So that's the first thing, that I would not use capecitabine and temozolomide in someone who did not have a pancreatic neuroendocrine tumor. as I've said, I'm not a huge, I think that there are other ways to treat people, and that I would always use in someone in the 90+% of people with grade 1 or grade 2, I think PRRT, which is peptide receptor radiotherapy, or Lutathera is the brand name, would always slot in before everolimus. We can have a discussion about CAPE-10 because I think the results are fairly similar between PRRT and CAPE-10 in pancreatic neuroendocrine tumors. My own personal bias has been to do PRRT earlier up front because it has the advantage of, even though pills are not that difficult, the advantage of PRRT is that you do it, it's 4 times over 6 months, and then you don't need to do anything else other than continuing your somatostatin analog shots. So that's kind of a long answer, but definitely in the pancreatic neuroendocrine tumors, I would do CAPE-10 first, unless there was some reason not to do it.
Thank you for that. And what about those who cannot get PRT or who PRT did not work for them?
Wow, that was well timed. And so some of it depends on why they can't get PRRT. I would want to make certain that they really truly can't get PRRT. The most obvious reason would be that the dotatate scan was negative, and that that patient is in the 10% or so people who just don't light up, and they do not have adequate somatostatin receptors. And in fact, the tracer for these are the brand names, but for a gallium, for NetSpot or DetectNet, which are gallium-68 or copper-64 dotatate scans, is basically the same as what's used in PRRT. So first, I would say, well, why can't they get? If they're negative, then that makes sense. No one will do that. Then, as I mentioned, for someone who has a pancreatic neuroendocrine tumor, definitely use CAPE-10. There are other drugs, of course, that are useful. I would actually probably use a small molecule inhibitor, and the one that we're sort of right now, our fashion, is lenvatinib, which we've been able to get before I gave everolimus. And someone who was dotatate negative, who had a non-pancreatic neuroendocrine tumor, grade 1, grade 2, who is dotatate negative, then my options are more limited. I think everolimus is a reasonable option, and even though they're not approved, small molecules, as I mentioned before, even though the response rates aren't as high, is also reasonably an option. Now, if someone had PRT and did not work for them, there are actually that encompasses two different groups of people. So there are people who are primary refractory, meaning that the tumor grew, and about 85% of people will get some benefit from PRRT. But that means there are like 15% of people who, on the first scan, which is done at least at UCLA in collaboration with my nuclear medicine colleagues, about 3 months after you finish, that it's worse. And so then I would say that those patients who are primary refractory are that you need to do something else, and that sort of goes back to what I just said. Now, if you had PRRT and it stopped working, at some point it will stop working, and median time for it to stop working is 2+ years, and the longer that you go, the greater the chance that actually salvage PRRT may work. And so what we know, and this is over decades of PRRT, back in the old days when it was each institution made their own before it was standardized, but there are clearly patients who did well with PRRT, had stable disease, or less commonly had a response, and it took a long time for their tumors to grow, and they benefited again from PRRT. And our cutoff, and we were just discussing this morning, is that the tumor should not have worsened in less than a year after you started. So that's 6 months after you finished. So if someone's tumor had PRRT and the tumor grew a year after you finish, then salvage PRRT is a reasonable option. I'm not saying that's necessarily where I would go next, but it's still in your, it's still in your back pocket. It's still one of the things that you can do. And in fact, the longer someone goes, the more likely I am to be able to, to go to that. Now, I think I may have briefly mentioned that there are other agents that are in development, particularly alpha emitters. We hopefully will be opening a trial with one of them in the not too distant future, though it is a randomized trial. And I think that people who failed PRRT but who are dotatate positive may still be an option for them in the future.
Thanks. That's helpful and hopeful
Mhm.
that there is other options. So you mentioned lenvatinib. Believe it or not, there's a question about lenvatinib. Can you talk about lenvatinib, the dosing, side effects, and how or why you might pick one TKI over another?
That's a really good question. And the answer is there is no data really comparing one to the other. I would say in non-comparative trials that the next generation tyrosine kinase inhibitors, such as cabozantinib and lenvatinib, seem to have higher response rates, though these are not head. In fact, there are very few head-to-head trials in neuroendocrine tumors. I think that the dosing we've been using has been low dose, like 8 milligrams, and it seems to be well tolerated. Side effects of all these drugs include fatigue. People can get hand-foot syndromes. People can get GI side effects. My experience, I have to be honest, I don't have enough experience, which would take many, many, many patients to say whether this makes a difference in efficacy, but it certainly seems to make a difference in tolerability. One thing that I mentioned before is that we are lucky in a way that a lot of these questions have been worked out in other tumors. And
Mm.
so these were not drugs that people came up with for neuroendocrine tumors, but we're happy to use the experience from other diseases. What we know, particularly for lenvatinib, is that, and I'm a part of what I do is drug development, is that they basically came up with probably too high a dose. And that's been done many times. And the dose that's really in the package insert is probably, at least in other cancers, too high to tolerate well. Now, some people may, and that's great. They may have to do with how they metabolize drugs, but we definitely start low. In fact, there's another
Thank you.
drug that's similar that's used in colon cancer called regorafenib, and these are all very similar. And we clearly got the dose wrong. And so, in fact, in that disease, we've totally changed how we dose it and became much more tolerable. Even capecitabine, which I talked about for Cape Tem, if you look at the original dosing, it was way too high, and it was
Mm.
the original that was in the package insert with the original approval from the FDA was way too high and very different than what we use.
So what dosing would you start at with lenvatinib?
8 milligrams.
Okay,
Yeah.
thank you. So
Sorry, long
shifting over to
question, long answer to a short question.
yeah, no, that's a lot, and
Mhm.
it's new to many people, so that's helpful. Shifting to somatostatin analogs, what is the main purpose of lanreotide? To suppress hormones that cause symptoms such as diarrhea, or to suppress tumor growth? And is there supporting data? And I know you went
And
over some of the
yeah,
studies.
and the answer is yes to all of the above. And so the answer is yes, yes, yes. And so so lanreotide, which is another somatostatin analog, was actually developed a little differently. So octreotide, which is older, was actually developed for symptom management. And it was only kind of later that we realized that some people's tumors, single digit percentages, but shrank. And also that we had seemed to have really long, stable disease. And that led to those trials, that I mentioned, like the PROMID trial, which was done with mid-gut carcinoids, but still is applicable. Then lanreotide, the clarinet trial, it was developed for both. So I would say the answer is yes to suppress hormones, and it is very effective for that. It has also been shown in that trial to delay progression. I would say that just like octreotide, the actual major tumor shrinkage rate is small. In fact, it's very small. However, the stable disease rate is actually very high. And they have randomized trials, the highest level of data.
Thank you for that. And
Mhm.
um, and another question is, what's the average time for the somatostatin analogs to stop working?
In some ways, it doesn't matter. What matters is it's a long time, but what matters is to the patient. And so averages, I think this is really important. When you're the physician, you look at overall data, and you look at the studies, but there are a couple things. One, as I think I briefly mentioned, for example, the patients who went into the PROMID trial and the patients who went into the clarinet trial were actually somewhat different. And the absolute numbers that you get are really dependent on which patients you get in. In fact, one of the trials actually really wanted sort of they wanted to hurry up and get their data, so they actually chose a worse group of patients, people who had progressed relatively rapidly, and so in order to put them on study. So it can, but averages don't matter to a patient, or sometimes we tend to use the word mean, which is, or instead of average, and we tend to use actually the term median, which is the person in the middle. And I've had patients on a somatostatin analog for more than 15 years. And there's some patients, as I mentioned, where it doesn't work. So, but what I would say is that often it's measured in years, particularly for the lowest grade tumors.
Here's another sequencing question, and I know we didn't really talk about this today, but is surgery typically the first line of treatment?
Well, this is medical treatment. And the answer is it depends. Um, for example, if someone has a localized pancreatic neuroendocrine tumor, surgery is first line of treatment, maybe the only line of treatment if you can resect it and remove it. We also use surgery sometimes for debulking, and that's a whole different discussion. But in patients initially who present, and the liver is the most common place for these tumors to go to, if you can remove the bulk, most of the tumor, there's some imperfect data that those patients do better. There are not randomized trials with looking at that, with debulking. It's not unreasonable and is often done at the same time. Now, in non-pancreatic small bowel, particularly small bowel carcinoids, as I mentioned, the most common place is right where the small intestine, the very end of the small intestine, the ileum, goes into the colon, the large bowel. And often those patients will have obstructive symptoms. And so the primary tumor can be relatively small, but two things that can happen. One is that they can have very large lymph nodes right next to there. In addition, because of the hormones that are made, there can be an awful lot of scarring. So what we tend to do is, even in people with metastatic disease, we don't do this very much in oncology, but even in people with metastatic disease, unless it's not practical, we often actually, we meaning the surgeons, not me, will go in and operate and remove that to prevent further obstruction. And it's not uncommon patients to present with years of intermittent obstruction and turn out and not have a lot of the classic, flushing or things like that. And it turns out that they have an ileocarcinoid. Now, let's say someone has something that can be resected and that's all there is. Then I would say, yeah, you go to surgery.
You talked about treatment of diarrhea. How do you know for sure that diarrhea is due to carcinoid syndrome?
That is a really good question. And the answer is it's a work in progress, and that you have to work with each individual patient. So first of all, most of patients, let me step back one second. Just having had a neuroendocrine tumor, if there's no evidence of disease and you have diarrhea, you do not have carcinoid syndrome. So that's easier. And in fact, in general, particularly for GI carcinoids, which is what I take care of, that patients who have neuroendocrine tumors that have not spread to the liver don't have carcinoid syndrome either, because the hormones get sent to the liver where it gets chewed up metabolized by the liver, and they also do not have carcinoid syndrome. So if you have a patient who has a neuroendocrine tumor and has liver metastases and is having diarrhea, you kind of work your way through this. And some of the tests are pretty easy. For example, if you want to look for pancreatic insufficiency, that's a stool test. Most of these patients have already, I'm not doing this in perfect order, but most patients who have metastatic disease are already on a somatostatin analog. And a lot of what I do is actually asking history. For example, like I mentioned, well, maybe like after the shot, the diarrhea is controlled, but if it seems to wear off in the last week, then that's telling me the diarrhea is probably due to the neuroendocrine tumor and the hormones that are made, and I just need to either increase or shorten the interval. Otherwise, I work with our gastroenterologists and to see. Kind of empiric. The key thing is, what I was trying to say is that, look, a lot of my patients who have neuroendocrine tumors and have diarrhea, it's due to their neuroendocrine tumor. However, the key I also see, particularly out in the community, people feel that everyone who has diarrhea and has a neuroendocrine tumor, that it's due to the hormones, and that is not necessarily true. And for example, if you have someone who had flushing, who's now on a somatostatin analog, but the flushing is all better, but the diarrhea persists, that makes me feel more strongly about looking for other causes.
Okay, thank you for that. Second to last question. As you know, the NCI recently opened a trial with Lutathera and a PARP inhibitor. And I was wondering, are PARP inhibitors, this person's wondering, are PARP inhibitors like olaparib effective in blocking tumor cell repair?
What I would say is that PARP inhibitors, I have to be honest, I'm doing more pan cancer, have been unfortunately not as promising as we had hoped. So what I would say that they're relatively effective in ovarian cancers in general, and particularly people who have a specific mutation, which is called BRCA, where they do have problems with DNA repair. Not so much cell repair, but DNA repair. Recently, though I don't follow this literature that closely, that there actually were some withdrawals of approvals where patients just did not do quite as well, even with ovarian cancer. In triple negative breast cancer, these are modestly active drugs. It's particularly, once again, only in those patients who have BRCA mutations. In pancreatic adenocarcinomas, so different types of cancer of BRCA mutations, I would say and I've worked with this, they're modestly active drugs. Once you get beyond that, there's some theoretical reasons to do this. Actually at UCLA, with my colleague Zev Weinberg, we just published this, looking at combinations of other drugs, including one I'd mentioned earlier, irinotecan, to see whether or not we can expand from those patients who already have an inherited DNA repair problem in their tumors. So I would say that I would not use it anywhere, any way, any form outside of a study. I will say that with other chemotherapy drugs, it is extremely difficult to combine with and that's actually was our trial, where we gave extraordinarily small doses of other drugs plus a PARP inhibitor, which is called talazoparib. So I think it's interesting. There's some theoretical reasons why radiation, which is with PRRT, it might be a radiation sensitizer, but I would not do that outside of a study.
And what about in the study? Is that a study that you would be interested in?
As I would say that, first of all, these drugs also, they're targeted, but they definitely have toxicity. And I certainly have seen the toxicities from them. I mean, they cause low white blood cell count. They can have GI side effects. They can have, so even though they're targeted therapies, they're not totally benign. So I'd have to think about whether or not I would do such a trial here. I'd have to go back to the preclinical. But having done a lot of work at combinations of other cytotoxic chemotherapy drugs, which muck up DNA, and that's what radiation does. It mucks up DNA, and it makes sense because these affect the DNA repair pathway. I would be somewhat concerned about, I'd like to see what early data, and I'm not familiar with it, but I would say I would be really concerned about side effects from this.
Okay.
I'm all for people going on trials, don't get me wrong. And just for those of you who don't know, the way that we find these things out is by starting with really low doses and working things up. And so that's in stage one, actually would be called, stage one, phase 1B, which is combinations. They would start with standard dose, I'm assuming PRRT, and starting with really, really low doses of the PARP inhibitor to make certain that they're safe first, to get a dose to carry forward into a larger trial.
Thanks for that. The last question is, what final thoughts or words of hope do you have for the NET community?
Wow, that's a great, wrap-up question. And so, first of all, I think one of the biggest things has been the explosion of interest and drugs that has really happened over the last decade or so. And at one time, and I think a lot of this I have to give credit to people like Lisa and the rest of the LACNETS community, where it shows that a mobilized, interested motivated group of people, really can do an awful lot. And they can do an awful lot for themselves, and they can do an awful lot for other people. And I think it shows how important it is to keep that mobilization, to get people onto studies, to get funding. As I always say, money is the mother's milk of research. And it's really true. If you don't have funding, you can't do these trials. And so I think that's truly that it's on the radar. It was way below the radar when I first started. So that's a word of hope, because if you're not doing research, I didn't come up with this, but the cure to cancer is research. And if we're not doing research, if no one is thinking about it, so that's clearly words of hope. The other thing is that we're learning more and more, I would say, about the genetics of neuroendocrine tumors. Both why people get them, and we're going to be part of a UC-wide trial that's actually Emmy Bergslin now is running. It sort of switched through the UCs, where we're looking at patients with pancreatic neuroendocrine tumors, looking at their genetic makeup to see maybe why they ended up getting them. But even though the number of mutations in neuroendocrine tumors are relatively small, I think as we learn more and more, that may be a place where we can truly have targeted drugs. So stay tuned, stay involved, keep pushing, and I think there's lots of hope.
Thank you for those words of hope. Research matters, and we want to commend the engaged patients in the patient community. And we also want to thank you for your commitment to patient care and research.
Oh, thank you.
Thank you so much for all you do for the NET patient community. And thank you for all of you who are tuning in today as well. So I'm going to send it back to Lindsay in the studio.
Thank you so much, Dr. Hecht and Lisa. Be sure you're following LACNETS on social media. We have Facebook, Twitter, and Instagram. Stay up to date on upcoming webinars and NET news. Now I'll pass it back to you, Lisa, to close us out.
Thank you, Lindsay. We offer many programs and resources, including our weekly virtual NET support group, a dedicated virtual caregiver-only support group, and health coaching, just to name a few. Go to our website, lacnets.org, to find out more information about all our programs and resources. LACNETS has developed a couple tools to help patients and caregivers learn to speak NET. This includes NET Vitals, a patient-physician communication tool to help you prepare for your medical appointments by downloading and filling it out as a self-assessment tool to give you the opportunity to look some things up before your appointments and highlight the questions you have for your NET expert. It also helps you organize all the vital information about your NET in one document. We also developed our NET Intro tool as a quick way for you to share your NET history in 1 to 2 sentences with someone like a healthcare professional or a patient advocate who needs to understand key information about your disease. We've created a printable wallet-sized card that you can fill out and carry with you and have handy. LACNETS also has a podcast featuring NET experts who answer the top 10 questions in their field every month. We encourage you to take a listen. Thanks again to our special guest for today, Dr. Randy Hecht. We are grateful for all you do for the NET community. Thank you to Rich at TVP Live and to all of you for joining us today. Goodbye and see you next month.